Okay, we're live. We're live.
Hello. Hi. Hello and welcome to our live event on robotic surgery and colorectal cancer enhanced recovery. I'm your host, Dr. Schehrezade Khan. I am a hospitalist at Providence St. John's. And if you don't know what a hospitalist is, it is the doctor that takes care of you while you're admitted. Joining me today is Providence St. John's Health Center Chief of Surgery, Dr. Tracey Childs, MD, MPH, FACS. As a reminder, the information provided during this event is for informational purposes only. If you have any medical questions, please reach out to your primary care or healthcare professional. Hey, Dr. Childs.
Hey, Schehrezade.
Hi. For those who haven't met you yet, please tell our audience a little about what you do at Providence.
I'm a colon and rectal surgeon. I do general surgery and colon and rectal surgery, so that encompasses both benign and malignant disease. I also have a leadership position at Providence St. John's and have been the chief of staff and am the acting chief of surgery right now, actively involved in lots of other committees. One of my passions is I provide healthcare in Guatemala. So I am very actively involved in surgical missions in Guatemala. So that's a passion of mine. And another passion of mine is one of the things that we're going to talk about, and that is enhanced recovery pathways and how we use the current technology and pathways to make our patients well before and after surgery as quickly as possible.
Incredible. Learning about this enhanced recovery pathway is going to be one of the 5 bullet points we cover during this talk. Enhanced recovery pathways, also known as ERP, and can be used to help patients recover quicker after surgery, not just colon surgeries, but different types of surgeries. And now I'm going to kind of go back to an introduction onto why we're having this topic today. So you may or may not know, but March is the month for colorectal cancer awareness. This topic is near and dear to my heart. My father had colon cancer and was cured from it, and he was diagnosed from a screening colonoscopy. And unfortunately, my aunt passed away from colon cancer. It wasn't detected until it was too late. And this topic really is important to me personally and professionally. So I'm so thrilled to be able to give this talk. Dr. Childs, would you kind of start us off by telling us, what are the myths of colorectal cancer that you'd like to make individuals aware of?
The first myth is that there's no way to prevent it, nothing you can do about it. And so that myth should be busted right away. We offer, and hopefully it's accessible to most of our patients, colonoscopic screening or even screening for colon cancer. One of the most common ways to screen for colon cancer is what's called a colonoscopy, and that is after doing a cathartic preparation to clean out your bowel, you go off to sleep a little bit, and the provider puts a scope all the way around your rectum and colon. And what they're looking for isn't necessarily cancers. It's actually precursors to cancer or little polyps. And one way to prevent colon cancer is to screen for it, remove these polyps before they ever get a chance to turn into cancer.
That's incredible.
Yes.
So cancer screening. So you're saying we're looking for precancerous cells. The age, I will say here, the age for screening used to be 50, the big 50, but it changed some years ago, and now it starts at 45. But
45 in the general population, and actually in a family like yours, it would be 10 years before the onset of the first patient. So if your aunt had colon cancer at 37, then you could potentially start your screening at 27.
Yes.
And we
Yes.
need to make sure everybody understands that there's more than one way to screen for colon cancer. So colonoscopy is both potentially diagnostic and therapeutic in that you find something, a polyp, and you remove it, therapeutic, or you find something that is suspicious for malignancy and you biopsy it at the time. And so those are interventional ways, but there are other ways to screen for cancers. Some of them include just the old way used to be looking for blood in the stool. There are now immunohistochemical tests where they actually can look for cancer cells in a stool sample. And those are best for low risk patients. And another way is something called a CT colonography or virtual colonoscopy. So lots of people are afraid, well, you still have to do the bowel prep for that, but it's basically a CT scan that's kind of like Fantastic Voyage through the colon. And if they find anything that looks like a significant polyp or a potential malignancy, then the next step is to go on for colonoscopy.
Oh, that's very cool. So 3 ways to screen for colon cancer depending on your own personal risks. Colonoscopy, classic, the stool test, and then thirdly, the CT scan.
And can I interrupt for 1 second?
Of course.
We have to define what screening means. Screening is an evaluation in an asymptomatic population. So this is across the board, hit 45, have a screening exam. However, it's very different if you have symptoms. So if somebody is having symptoms that could possibly be related to colon cancer, crampy abdominal pain, change in bowel habits, blood in the stool, anemia, that's no longer a screening exam. That's actually a diagnostic evaluation. So nobody with any of those symptoms should be doing anything less than colonoscopy.
Got it. So super differentiating screening versus having symptoms.
Right.
So you mentioned a word, you said polyp, and commonly I hear people, may not understand the difference between a polyp and a cancer or a tumor. So could you bust that myth for us? What's the difference between polyp and cancer, and do I have to be worried if there's a polyp?
No. So I could safely say that most, if not all, colon cancers start out as a polyp. That's not 100% true, but we're going to use that as a premise. And what a polyp is a growth of abnormal cells on the lining of the colon. So the colon is a tube that's made up of several layers, and the internal layer is called the mucosa, and that is where all colon carcinomas come from. And if the changes in that tissue develop into uncontrolled cell division, that's where a cancer can happen. There are times where a polyp is removed, totally benign, and it's found that there is a small focus of cancer within that polyp. If that hasn't penetrated into the deeper layers of the colon, called the submucosa and the muscularis, and then the outside is the serosa, then it's potentially, occasionally, maybe rarely, cured by polypectomy.
I love that you said that, because cured is not a word we commonly think of when we hear cancer. And one of my driving points home for this talk is that cancer is not always terminal, and cancer is curable and preventable.
So we've talked a little bit about one way to prevent a cancer by removing the polyps before they have a chance to turn into cancer. It's kind of like why women get mammograms in order to identify early disease or precancerous disease. Same thing with colonoscopy and polypectomy. However, the morbidity and mortality, so the risk of spread of the disease and or death from colon cancer, depends on how far through the wall of the colon the tumor is growing. Always starts out on the inside and then grows through the wall. the farther through the wall it grows, the higher the risk of cells breaking off and getting filtered out by the lymph nodes and or spreading through the blood to remote places like the liver or the lungs. And so the whole idea is to find precancerous disease or early cancers which can be cured without any need for adjuvant therapy. That would be chemo and radiation. And I think this actually is a good time to talk about the difference between colon and rectal cancer. So you all, it's, this is colorectal cancer month. This is, we all talk about colorectal cancer. The rectum is the end 12 to 15 centimeters before the stool comes out your bottom. And the rectum is anatomically different than the colon. And so the evaluation and the treatment of rectal cancer is actually very different than colon cancer. So today we're going to talk about colon cancer, and we are happy to come back and talk about rectal cancer at a separate time because it's a whole different ball of wax.
Absolutely. Thank you for that differentiation. A lot of people may think that the treatment is the same because the rectum is an extension of the colon. But as you've just said, it's different.
Very different.
So colon cancer is the third leading cause of cancer-related deaths. And I think Dr. Childs was mentioning that it changes every so often, but it's definitely in the top three, and it's always been in the top three. So this is why we're continuously talking about colon cancer screening. And Dr. Childs, can you tell us a little bit about you as a surgeon personally and how you treat patients when they come to your office with questions?
Absolutely. So I have a philosophy of partnering with my patients. Occasionally we'll have a patient who says, just tell me what to do. And that's just not the way we do things anymore. So because there are choices in evaluation and choices in therapeutic interventions, I like to partner with my patients and find the pathway that will not only fit their understanding and their lifestyle the best, but also basically promise the best recovery. So when we talk about partnering with patients, I make them understand that, it's my job to help them get through this, but that they have to have a stake in it also. And so when we talk about enhanced recovery pathways, those actually start before surgery.
Right. Right. Yeah. I love that you said that doctor-patient partnership, and the responsibility lies in both parties. And so you kind of get the patients to enroll in their own wellness and their own well-being. And let's be honest, the treatment starts in the early moments that you kind of make the appointment with your doctor, you walk in the room, you sit and chat, and that's amazing. So you mentioned enhanced recovery pathway, and for shortening purposes, people call it ERP. And one of the points of this talk is to educate people on things that doctors talk about, that doctors research, that if a surgeon would see another surgeon in the office, they would ask this question: do you use or do you follow the enhanced recovery pathway? Dr. Childs, could you tell us a little bit more about when it was developed and what the bullet points of an enhanced recovery pathway really is?
Right. And so I don't know if you can put up the slide on enhanced recovery pathways. And I'm sorry, I'm actually just looking at my slide right now because I can't see the screen. So enhanced recovery pathways involve preoperative, intraoperative, immediate postoperative, and delayed postoperative phases. And so in terms of preoperative partnership, one of the things that we do is something called nutritional prehabilitation. And so it's really important for patients to be healthy enough to have surgery. That just doesn't mean protein and calories, but there are actually some special drinks that have micronutrients in them that have been proven to help with wound healing and avoiding infection. So have to engage my patients into buying into the fact that drinking these special drinks is going to make a big difference. Another thing that's really important in enhanced recovery pathway is narcotic sparing or opioid sparing. So I always tell people this ain't your grandma's surgery, you know, where when you had surgery, you had big incisions, you loaded them up with narcotics. A while back, there was, you know, patients weren't allowed to have any pain after surgery. And now it's very different. I explain to my patients that you're having surgery, minimally invasive surgery, laparoscopic or robotic, and we'll talk about that, affords smaller incisions and therefore is less painful. But I do tell people you will have pain after surgery, and we will help you manage that pain, but you have to manage the expectations. The more we can avoid narcotic, and I will tell you that in 75 to 80% of my patients now post-operatively do not need or get narcotics. That allows a quicker recovery. No nausea, no dizziness. They're able to eat better. They're ambulating right after surgery, and they don't get constipated. We talked about minimally invasive surgery as being part of the enhanced recovery. Early feeding. No longer are you starving in the hospital either before or after surgery. And in fact, the NPO after midnight thing is a big myth. We actually have patients drink a quart of Gatorade right as they hit the hospital so that they are not low on sugar and they're not hungry and they're well hydrated. And then after surgery, we don't wait 6 days or 10 days like we used to before you feed the patient. You don't have to fart or poop before you get food. We start feeding you right away. And as long as you're not nauseated, you get to eat and drink, which actually stimulates things and helps your recovery. We get you out of bed and walking, which is easy because you're not stoned on narcotics and you don't feel all loopy. And then we get you home and we get you up and involved in your normal activities. And so in the day when I started, a colon cancer surgery would be, you know, a week in the hospital and 6 weeks recovery. And now you're a day or two in the hospital and you're driving back by yourself to see me in the office in a week.
That's amazing.
It's an amazing thing.
What a game changer. I personally, I'm internal medicine trained. So I learned this preparing for this talk, which is an enhanced recovery pathway, nails home 5 or 6 bullet points. It was developed 5 years ago from a previous pathway or program that was also trying to help patients rehabilitate from surgery faster. And I personally take care of Dr. Childs' post-ops in the hospital, and they do really well. And I think this prehabilitation, so if like there's 5 or 6 points of ERP, the prehabilitation, the not using narcotics for pain management, the minimally invasive surgery, the early feeding, and early ambulation really help with both the psychological stresses of surgery and the physiological stresses of surgery. And it's so nice to kind of share that information earlier and sooner so people know what to expect. Let's talk a little bit about, I just thought of something. Let's talk a little bit about how this changes.
Upgrade their home.
So how this changes the screening ages for colonoscopy and how, like maybe I'm sure some people have heard you don't need a colonoscopy anymore. You've reached a certain age, and maybe if we found something, we wouldn't know what to do with it anyway. And so, Dr. Childs, would you comment on that?
Well, I'm going to comment on 2 ends. Okay, so I think that if I'll probably go to jail for saying this. I actually think colonoscopy, at least one colonoscopy, is important for baseline. And if somebody has a colonoscopy who is at average risk and there are no polyps, then you have a colonoscopy 10 years later and there are no polyps, you potentially could go to one of these other screening methods like the FIT method, which is the, checking the right. If you have polyps, though, and they're significant polyps, you're going to have your colonoscopy more frequently, maybe every 1 to 3 years.
Mm-hmm.
If you've had polyps your whole life and you're 85 years old, you may need to continue having colonoscopy. Because it used to be that if we found something, what were we going to do anyway? You're too old to have treatment. But we know that's not the case anymore. The fact that, octogenarians and nonagenarians are so much more active and healthy than they were in the day. And our surgical approaches to treating these cancers allows for a very uneventful recovery. We need to keep people as healthy as we can.
Yeah, I agree with you. They commonly say the benefits of screening decline after the age of 75, and this is my anecdotal personal data, but I personally believe and see we're living longer, we're living healthier, and I've taken care of some amazing, 80, mid 80s, early 90s folks who are living their life pretty independently, and so it's really nice to hear. That there is a minimally invasive colon surgery to kind of cure and treat colon cancer.
Talk about minimally invasive surgery. So colon cancer surgery used to be big incision up here. It took a lot to get over. The incisional hernia rate was 40 to 50%. Many years ago, we went to laparoscopic and laparoscopic assisted surgery, which still involved a 6-centimeter incision in the midline, which we used as a hand port or an extraction site, still with the same 40 to 50% incisional hernia. And a lot of times the mobilization was all done minimally invasively, but the actual resection and put back together again. Oh, that's another myth. Put back together.
So what was the recovery time from a laparotomy, an open incision?
I'm telling you,
versus now.
6 to 10 days in the hospital and 6 weeks for full recovery. At Lap Assist, it was, 3 to 4 days in the hospital and then 6 weeks recovery. And now it's 1 to 2 days in the hospital in general. And most people feel about 80% at 2 weeks. But what I started to say was, so we'll talk about where now we've transitioned into, or I've transitioned my practice into robotic assisted laparoscopic surgery, which instead of minimally invasive surgery with straight sticks, it's 3D high definition visualization and wristed instrumentation, as well as I have 3 hands instead of 2, which allows me to do all the mobilization and the resection and the put together all on the inside, and then make a very small incision as an extraction site, bring that off the midline so the incisional hernia rate is very low, the discomfort is very low, and the sort of the side effects, if you will, of pulling the bowel out through the abdominal wall and doing the resection and the put together on the outside, that all goes away. So the swelling and the swelling on the inside gets better too. And so I don't know if you could put up that slide of the robot, but
yeah, we just saw that slide of the photos of the machines with the arms.
Yeah. That's the robot itself, and then the little square thing is the console, and that's where I sit and put my head in, and I can see things that in my day when I was being taught and my mentors could never imagine. I mean, and it's been a blessing to teach an old dog new tricks. And I will also share something with you. I had the unfortunate opportunity to have a robotic surgery myself a couple months ago. So after drinking the Kool-Aid as a provider, I had my procedure done robotically, and I was up and around the next day, and I was taking a walk at the beach the second day, and I drove myself to the beach to take a walk the third day, and I was back to work in 5 days. And I'm not professing that everybody should, try to get there like that, but it's possible. And so I can speak as a robotic patient also. It's a game changer. Can I talk about one more myth? Because I know.
Yeah, sure. Go ahead. And thank you for sharing that. That's awesome.
Yeah. Here's another myth that all colon cancer surgeries and patients end up with a bag.
Yes,
And I
that's
think
exactly what I was going to talk about next. Yeah.
excellent. And I think it's really important. My patients can't even hear what I'm saying when I'm talking to them about it until I get to the part where I, say, and the likelihood of you needing to have a colostomy is minimal. And then all of a sudden you can see their bodies relax and so I have started out by saying that in the very beginning so that they can relax and hear the rest of what I'm saying. But the likelihood of requiring a colostomy with colon cancer itself that's treated electively, and I don't mean it's cosmetic surgery, but it's not emergency surgery, is the norm. The colostomy with emergency surgery is more common, and that's why we like to try to avoid emergencies.
Yeah, that's wonderful to hear.
Yeah.
Well, I'm just checking in with the private chat. There's no questions yet.
Can we show the pictures of the patients?
Yes, the picture is shown now of a young man who.
Oh, okay. So this is a gentleman who had a colon surgery 8 hours prior, and he's in his sweats, and he's standing at the door, and he's been taking a walk, and he's showing you those little incisions, and that's what robotic surgery is about.
And he's standing like a superhero, so he must be feeling well.
Yep. And I don't know if the other picture went up or not, but
yes, the other picture is up just now as you said that. And what are we seeing here in these 3 photos?
So what we're seeing here is a gal who had to have an urgent colon surgery, which we were able to do robotically, and she's a set dresser. So she was back on the set in clothes, on her hands and knees, crawling around, doing her job 3 days after surgery.
Oh, wow. Yeah. And hands and knees, that's a pretty active job. So
that's why I love that picture.
I love that. I love that.
Like I said, this ain't your grandma's surgery anymore. It's a new world with new approaches and new surgical treatments and new and improved prognoses. And the whole goal is to have the patients be involved from the get-go, through the surgery and afterwards, and get back to their lives.
Absolutely. What great information. Thank you for sharing all of that with us. And also, thank you to Dr. Childs for joining us today, and to everyone listening and sending in your questions. Any last minute
were there any questions in the chat? Or I don't even see the chat.
I see it, and there are no questions as of yet. If you're looking for medical advice, please visit providence.org and make sure to follow Providence on social media at Providence on Twitter and under Providence Health System on Instagram, Facebook, and LinkedIn. As a reminder, the information provided during this event is for educational purposes only. And if you have any questions requiring medical attention, or if you have any conditions or treatment plan questions, please consult with your physician. And thank you so much for your time.
Bye-bye.
Bye.